I'll go on to showing two cases, and these are the tricky situations where patients are having or demanding a multifocal lens. So this is a case where you are having a subluxated cataract and the patient was wanting a multifocal lens. So we go ahead and start with the capsular axis. Light बहुत कम है, हाँ. And you can see the hydrodissection that is being done. And to stabilize, one is looking at maybe doing an endocapsular ring. And you can see right there, there's a surge that happens. And the obviously the thing gets complicated. There's an endocapsular ring and there is a nuclear fragment that has gone behind. So we have to take out the endocapsular ring, 23 gauge sutureless. This is tricot that's being injected, and we have made the flap for a glued IOL, and you can see this is the removal of the lens fragment which has fallen down. So this is being done by our retina colleague, and this is the old bifocal lens that we used to have earlier from Pharmacia, and now then it was over to Abbott. And you can see this is a three-piece lens with PVDF haptics, and a scleral tunnel has been created with a 26 gauge needle, and the haptic is tucked into the scleral tunnel. So you can see this is a glued IOL that has been done in case of a situation where there was a subluxated lens, and you can see a well-centered glued IOL. So this was a difficult case that was handled with a multifocal. Now, coming to another tough case, which is operated 14 years back with a twin set bifocal Acritec 733 IOL. The haptics used to come out in these lenses. There was a YAG opening which is there. Original power sticker is there. Now, what the patient still wants multifocality, and you can see in this particular case, this is the lens, and you can see pupil is allergic to tropicamide, so we can't use that. So we use cyclopentolate in this particular case, and you can see as to the acute amount of displacement which is there, and it will be known during the surgery as to what was the reason for this. And we go ahead, and this is a capsular opening which you can see a YAG capsulotomy has been done in this particular case. We go ahead and consider as to what has to be done. So we will go ahead, and you can see, can you see that small little nick or the line there? That is where the original haptic was. That is where the original haptic was, which got taken out, and we are using intracameral epinephrine to kind of dilate the pupil. You can see that the pupil dilates, and you can see that those are the haptics which have got dislodged, and that is the reason why the lens got displaced. Now, what was the reason for such uh, dislodgement of the haptics? One really does not know. So, what do you have to do again? Using tricot to do a good vitrectomy, because you can see that there's a big round posterior opening which is there. And so what one has to do is to go ahead and do a vitrectomy from the anterior root. You can also do it from a pars plana, which will be preferable if you have a vitreous surgeon. You can see how the lens is moving because there is no haptic support there. And we will go ahead and hold this with the forceps. You can see it's a serrated forceps. You don't have to cut the lens through and through right till and break it into two parts. So this cartwheeling can happen if you just go up to the middle, and you see once we pull the lens out, half of it comes, and then you can see that the other half will come out. So that is the lens which is coming out, which you can only cut right up to half of it. You don't need to go through and through. Once you have done that, whatever haptic is stuck, was not stuck, was removed. But the haptic which is well stuck, we will leave it there. Do a good vitrectomy which is there. This again, you will have to use a three-piece lens. A single-piece lens is not going to give you adequate because you have to put it in the sulcus. The posterior capsule is obviously there's a big capsulotomy opening. So this is being done under topical anesthesia, and you can see that this is the three-piece again lens, which is a bifocal lens, which is being implanted. Nowadays, you have more of trifocal than synergy, etc. But this is so you can see that this lens and this has been put into the sulcus, and you can see the anterior capsule. There's going to be a capture. There's the old haptic which we haven't taken out, and this is the bag which you can see where the capsular uh, the lens is captured into the anterior capsule, and any vitrectomy, any remnants that are there, that is being done to see that this is totally free. Aage kar do. And you can see that we have been able to achieve a well-centered IOL in this particular case. So these were two situations that I said, which were tough situations, obviously calls for tough decisions and use of your skills to the best ability so that you can get good, well-centered multifocal IOLs where the demand from the patient is there in the absence of posterior capsular support or inadequate posterior capsular support. Thank you very much for your kind attention.
Thank you, Mahipal. The lens that is showed, the Pharmacia lens, I don't know how many of you use. It's called, there was no way to put, the injector for that lens failed. So the only way to put in that lens was to have a 3.84 millimeter incision, and we needed to use a holder folder. And by mistake, if your staff gave you a wet folder, that lens will fly off.
Yeah, it was silicone.
Yeah, because that was a problem then. And I put these lenses in my mom, and she's now 86, but she's an MBA, and she still does my accounting. So this lens still works beautifully. It's an excellent square edge, no PCO, little myopic, but doing very well. So it stood the test of time.
That's why your figures keep on growing, because she does your accounting.